Today I'm going to talk about another very important topic in emergency department, that's diarrhea. This is the most common presentation patients come up with in emergency department. Most of the times it's self-resolving and it's viral in etiology, but there are some few significant warning signs that warrant adequate resuscitation and excessive investigations to get to the diagnosis. So, what is diarrhea? Diarrhea can be defined as rapid passage of excessive fluid stool or stool that take form of a container, rather remaining as intact stool. It is said that intestine can absorb around 9 liters of water and about 100 ml in excreted in stool. It's the other way around in diarrhea. Alteration in this process can lead to diarrhea. This can be due to increased volume load in GIT tract. That's called secretory diarrhea. This can be due to decreased absorption by the bowels. That's osmotic diarrhea. This can also occur in inflammation or increase in gut motility. So diarrhea is watery stools more than 3 per day. Toxic agents can cause secretory diarrhea, which includes E. coli and Vibrio cholerae. Osmotic diarrhea occurs when unabsorbable or poor absorbable molecules such as lactulose challenge in the small intestine. Inflammatory diarrhea occur is due to inflammation and inflammatory process that cause leakage or decrease absorption of fluids. These all can cause diarrhea. Before going further, let me explain to you how to approach a patient in vomiting or diarrhea. Because you're concerned about is the outcome of vomiting and diarrhea. What should be the disposition of this patient? First, let me summarize you an approach. If a patient comes to you with vomiting or diarrhea, first and foremost thing, look for vitals, which includes blood pressure, heart rate, pulse oximetry, temperature, and GCS. That's Glasgow Coma Scale. Look for respiratory rate, pulse oximetry, rectal temperature. Why is these vitals so important in every disease that you come across in emergency department, particularly diarrhea? Because of excessive fluid loss, there is dehydration inside, which causes reflex tachycardia, which is an early sign of fluid deficit. Blood pressure can be decreased, hypotensive. There can be increased respiratory rate, decreased pulse oximetry, or increased temperature. What do you have to do? Resuscitate. So these 4 vitals can provide you enough information that you can roughly estimate what the patient is going through. And even if you don't know what the patient is going through, but you know what to do in this patient. So look for sign of volume depletion. That's shock. How do you check shock? Hypertension, reflex tachycardia, decreased urine output, capillary refill, orthostatic hypotension. If the patient is presenting with these kind of symptoms, leave everything else. Put a large bore cannula, and start IV fluids. Take necessary blood samples, which include blood glucose, which includes blood complete pictures, stool RE if available. Look for ABGs, chest X-ray, and most of the basic investigations that you might need to help to get to the diagnosis. Then consider empirical antibiotics if you're suspecting the patient is due to septic shock, or the patient is in shock because of any infection or any source of infection that you can recognize. If the patient is stable, if the patient is not showing any signs of hypoperfusion or dehydration, look for something else. Is there any focal or severe abdominal pain associated with it? Is there signs of peritoneal inflammation, which includes guarding tenderness? If the pain proceeds with vomiting or diarrhea, what to look for in these kind of patients? Patients who do you think are showing any focal or severe abdominal pain, or with signs of peritoneal irritation, or that precedes vomiting or diarrhea, abdominal pain that precedes vomiting and diarrhea? What to look for in these kind of patients? Many things: acute appendicitis, intestinal obstructions, mesenteric ischemia, aortic aneurysm, abdominal aortic aneurysm, pancreatitis, volvulus, inflammatory bowel disease, ectopic pregnancies, toxic megacolon, gastrointestinal cancers, ulcer bleed. Much more to think in these kind of patients. But again, you have to go back and make sure the patient is hemodynamically stable. Stability comes first, diagnosis comes later. If these signs of peritoneal irritations, or there is no signs of focal abdominal pain, or abdominal pain is not preceded by any vomiting or diarrhea, look for some of the causes. For example, medications, toxic exposure, cholinergics or sympathomimetics, which can cause diarrhea. If there is signs of or history of toxin injections, look for toxin injections. What kind of seafood injections, food poisoning, any neurological symptoms associated with seafood injections. If there is, think of Clostridium botulinum. Think of necrotizing shellfish poisoning, and much more. But if there's no neurological findings and there is no history of seafoods, think of any antibiotics related diarrhea. Think of antacids, think of antihypertensives, think of multiple variety of drugs that can cause diarrhea. But again, first you need to make sure the patient is hemodynamically stable. So again, if a patient comes to you with diarrhea, vomiting, or vomiting and chest pain with diaphoresis, signs of myocardial infarction, think of myocardial infarctions. Think of unstable angina. Think of pericarditis. Think of congestive heart failure. Any trauma, abnormal neurological examinations. Think of cerebral bleed. Think of gastrointestinal bleed. Think of splenic rupture. Think of meningitis and encephalitis. So if the patient is not showing these kind of symptoms, look for any other cause, any travel history, any exposure to viral patients who are already diagnosed as viral gastroenteritis. There's much more to think in these patients. But again, rule out the life-threatening diseases. So moving on, so as you can see here, as I said before at the beginning of this lecture, the intestines have capacity to absorb fluids of more than 9 liters. So as you can see, normally there is increased reabsorption of water. But in diarrhea, as you can see, there is decreased reabsorption and increased electrolyte loss via diarrhea. So this is the main problem. The patient is losing water and some significant amount of loose stools if the episodes are significant. So moving on to the red flags. I told you before in my previous slide what are some of the red flags that need to be looked in a patient with diarrhea, with acute diarrhea. Red flags, you need to take a good history. But before that, I would like to explain and recall what are the red flags for diarrhea. Duration of symptoms of more than 2 weeks. Think of pancreatitis. Think of if the patient is immunocompromised or not. Recent ingestion of rice and food like which containing rice, think of Bacillus cereus and Salmonella. Camping near fish water. Fever or bloody diarrhea can indicate invasive bacteremia or invasive causes of diarrhea. Any change in new medication, if the patient is taking Clostridium difficile, can cause diarrhea. But what are the signs that a patient can present? Fever, tachycardia, hypertension, altered mental status, perianal fistula, dry mucous membranes, and poor skin turgor. But what questions you need to ask a patient comes to you with diarrhea? How would you describe the diarrhea? If it's watery, non-bloody, is it foul smelling? What is the color of the stool? How many episodes? As I said before, more than 3 episodes is diarrhea. What is the duration of the symptom? If it's more than 2 weeks, it's chronic diarrhea. If it's within 2 weeks, it's acute diarrhea. You need to look for causes of acute diarrhea in these patients. What do you think caused your symptom? If the patient knows, if the patient has been taking any food from outside or any vendor, or if the patient is taking it changes any new antibiotic, if the patient has a history of travel, what do you think? If how much a patient know about the disease is very, very important. Any recent history of travel, because at some developing countries there is lack of adequate amount of pure water, which can cause diarrhea. Lack of sanitation and poor water filtration plants can lead to diarrhea. Are you taking any new medication? Antibiotics? So what are the examination findings and or red flags where you can appreciate in a patient with severe dehydration or complications of diarrhea, basically fever, tachycardia, or hypertension, invasive diarrhea, altered mental status, Salmonella typhi, Shigella, and Campylobacter, dry mucous membranes, poor skin turgor, acute dehydration. All these signs of dehydration, tachycardia, hypertension, altered mental status, and dry mucous membranes. These all produce these are all signs of dehydration. Bloody stools, invasive diarrhea. Inflammatory is common with bloody diarrhea, but non-inflammatory are mostly without blood or pus in the loose stools. Fecal impaction, tumor or hair-spreading disease, perianal fissures or fistula, think of inflammatory bowel disease. So these red flags should be in your mind while discussing taking history or treating a patient in ED department, because this will ensure if the patient is good to go home or need further treatment or need in-hospital treatment. So important history related to diarrhea. What is the character of stool? How much is the stool? What is the consistency? If it's fluid, if it's semi-solid, it's naturally the way the stool should be. Is it the way that the stool should be? What is the color? If it's associated, if it's black in color, think of melena. Sometimes patients cannot appreciate if this is a blood or is this a normal color or the change in color of the stool. Odor, foul smelling, mucus, blood, bloody diarrhea, if it's flesh blood or clotted blood, pus, these are all signs of invasive bacteria. Blood, pus, these are all signs of invasive bacteria. Character, acute, less than 2 weeks, within 2 weeks, chronic, more than 2 weeks, recurrent, if it's occurring again and again, and how frequent is it? How much duration does it last? In the patients, especially with irritable bowel syndrome, there's a time period where the patient can present with diarrhea and at times can present with constipation. But they have a history. The patient can tell you that I have a history for a few days I tend to have constipation, and for other few days there might be diarrhea. So duration is important. What are the exogenous factors that can cause diarrhea? Diet, food from outside, reheated, recooked rice can cause toxins and can cause diarrhea. Medications. What are the any new medications that the person is taking for for any disease? Medications from Clostridium difficile. Travel history of traveling. If the patient is going to any developed countries, or the countries who are not properly developed, or the sanitations and poor hygiene is prevalent in those countries, can cause diarrhea. Exposure to other with same symptoms. Any family member, any friends who have been already diagnosed as gastroenteritis or is going through diarrhea, have you been having exposure with them, can cause diarrhea. Sexual habits. Any associated symptoms with it. Fever. Fever causes invasive bacteria. It's due to fever is due to invasive bacteria, but it can be due to viral. But at times, fever with diarrhea is most of the time is due to bacteria. Any nausea associated with it. Vomiting. Gastroenteritis includes nausea. Gastroenteritis includes vomiting and diarrhea. Abdominal pain. As I mentioned before, abdominal pain, look for three things. Abdominal pain, out of the blue abdominal pain, think of mesenteric ischemia. Preceded vomiting and diarrhea, and then abdominal pain, look for acute abdomen. Look for acute pancreatitis. Oral intake, if the patient can take orally, if the diarrhea is more with oral intake. Medical history, any previous GI diseases, malabsorption syndromes, if the patient is going through malabsorption syndromes before, HIV and AIDS, immunocompromised. These patients tend to have diarrhea for prolonged duration, chronic diarrhea in these patients. Endocrine, any endocrinological problem that the patient is going through can cause diarrhea. Diabetes can cause diarrhea. Adrenal insufficiency can cause diarrhea. Uremia, patients with nephropathy, patients with chronic kidney diseases, patients who are already on hemodialysis, but the signs of uremia prevails, which can cause diarrhea. So, what are the lab investigations that can help in diarrhea? Most of the times, lab investigations are not required in patients with acute diarrhea. If the patient is stable, if the patient is hemodynamically stable, can take orally, does not need or may not require an excessive amount of investigations. But baseline investigations for underlying infections, that is from complete blood count, look for hematocrit. What does hematocrit has to show? Signs of a dehydration. If the hematocrit is increased more than 45 or 48, sometimes it is said, it is called dehydration. If the patient is dehydrated. Look for any signs of anemia. Look for any signs of platelet deficiency. Look for any signs of neutrophils and lymphocytes that can help you diagnose specific bacteria or viral infections that increases neutrophils or eosinophils. Electrolytes, very, very important. What you tend to lose in diarrhea? Electrolytes. Electrolytes are very, very important. With hypokalemia due to excessive diarrhea or vomiting, what happens is that patient tend to have abdominal cramps. The patient can present to you with abdominal pain. When you see the electrolytes, potassium is low. The patient is going through hypokalemia. You need to replace potassium in that patient. Signs of dehydration, electrolytes are lost. So you need to adequately treat this patient, rehydrate and resuscitate in ER, and protect this patient for hypoperfusion of the organs, and to prevent the patients from going into hypovolemic shock. Fecal leukocytes, stool for RE. Look for leukocytes or any signs of parasitic infections in leukocytes. If in stool RE, if there are leukocytes, the patient is going through any bacterial infection, and this patient needs antibiotics to go with. Stool cultures, very, very important. What organisms are grown on the patient? Stool ova. One thing to remember at this point, fecal leukocytes, stool cultures, stool ova, these are not emergency procedures, but can help you diagnose the patient if you have the availability of, if the patient can be given outpatient or inpatient medical facilities within certain amount of time. You can send these patients so the patient can follow up in the next follow-up routine checkup. But in emergency, these two, complete blood count and leukocytes and electrolytes, are way, way important than stool cultures or stool ova. Giardia specific antigens, Clostridium difficile toxins A and B, E. coli toxins can be detected when lab investigations. Pregnancy test. Pregnancy test is important. Why? Because these females need to know if the females are pregnant. So there are wide variety of antibiotics or drugs that are contraindicated in pregnant females that might be helpful otherwise in patients with diarrhea. So you need to rule out pregnancy in females. So radiological diseases, radiological studies. Small bowel obstruction, get an X-ray or CT scan, preferably in elderly males, because elderly can mask the classical findings. So simple erectile abdomen X-ray or X-rays, abdominal X-rays can give you an ample amount of information if this patient is having any small bowel obstruction. Constipation, look for fecal impaction. As you can see here, this is fecal impaction, the stool that's encircled in this diagram. Look for toxic megacolon. Very, very important. These need radiological studies. So what are the causes of diarrhea? Differential diagnosis. Let's rule out some infectious diseases. Toxin producers, Aeromonas species, Bacillus cereus, fish toxin, Clostridium species, Cryptosporidium, E. coli, Giardia, helminths, Klebsiella pneumoniae, Staphylococcus aureus, Vibrio cholerae. These are toxin-producing organisms. It is said if the patient is suspected to present with these symptoms, with these suspected as the cause of diarrhea, these organisms, it is recommended not to give any anti-motility to these patients. Why? Because this can accumulate toxins inside the gastrointestinal system and can further worsen the outcome and can hurt or injure more organs inside the abdominal cavity. Invasive organisms, Aeromonas species again, Campylobacter is invasive, Entamoeba histolytica, Entero-invasive, E. coli, especially E. coli with special strain of 0157. Norvac agent is a viral etiology, rotavirus, as name indicates, viral etiologies of infections. Salmonella typhi can present with diarrhea, and later complications can present with cerebral signs. Shigella species, Vibrio parahemolyticus, and Yersinia are the invasive organisms that can cause diarrhea. Parasitic organism, Cryptosporidium, Entamoeba histolytica, Giardia lamblia, Isospora belli. So parasitic infections can stimulate IgE secretions most of the time. So eosinophils are increased in parasitic infections. So what are the non-infectious causes? Bowel-altering surgeries. It is said with patients going through a massive or a major surgery can either present with diarrhea or constipations. Constipation can be due to adhesions, and diarrhea because of altered bowel habits that can occur post-surgery. Bowel obstruction can present with diarrhea. Cancer can present with diarrhea. Constipation. At times, constipation, when it is relieved with laxatives or any other things that can relieve the constipation, can present with diarrhea for some times. Hyperthyroidism can present with diarrhea. Inflammatory bowel disease, ulcerative colitis, Crohn's disease, these can present with diarrhea and dysentery. Irritable bowel syndrome. These, as I mentioned before, have alternate period of constipation and diarrhea. So these can present with diarrhea or alternating with constipation. Lactose intolerance, most common in children. Laxative abuse, especially in elderly patients who are known as chronic, who are going through a chronic constipation, and they are prescribed laxatives. Chronic use or abusive use of laxatives can cause diarrhea. Mesenteric ischemia can cause diarrhea. With what differences in mesenteric ischemia? You can have occult blood and diarrhea. Reaction to medications. There are a huge amount of variety of medications of drugs that can cause diarrhea. So moving on to general treatment principles. But let me go back from where I started off. While you're approaching a patient with diarrhea, look for the signs of dehydration. What are they? Shock, hypoperfusion, hypotension, tachycardia, orthostatic hypotension, altered mental status. What does it show? This patient needs fluid resuscitation. So the mainstay of treatment in patients with diarrhea, with acute diarrhea, is fluid resuscitation. There are two types of fluid resuscitation and how to give fluids. You can give oral fluids, you can give IV fluids. That depends the severity and the type of dehydration if the patient is going through. If this is some or mild or some dehydration, oral trial is beneficial in these patients, and you can encourage this patient to get to drink more water, more fluid, and it can be easy to send this patient home with educational information about how to do fluid resuscitation. Further, if a patient is with moderate or severe dehydration, this patient needs IV fluid resuscitation. How do you do that? Large bore cannula, start fluids, and take the blood samples that are required. Empirical antibiotics is important, but first fluid resuscitation. So what are the general treatment principles? Pertinent history and physical examination is if this patient is if this diarrhea is due to infection or something else. If this patient is due to viral etiology. If this patient is having a toxic megacolon and surgical issues that is causing the diarrhea, these needs to be ruled out. Rehydrate, antimotility agents, or bismuth salicylate. Non-infectious, identify and address underlying etiology. Infectious, epidemiological clues. What is the prevalent diseases in your country, in your area these days? Any history of travel? If the patient is went to any other country which is having any epidemic or any outbreaks, and this patient can be infected with that. Daycare exposure, more prone to get diarrhea, more prone to get viral infections, more prone to get gastroenteritis. Foodborne, food from outside, reheated rice, especially in Vibrio cholerae. Antibiotics associated treatment for Clostridium difficile can cause diarrhea. Skin contacts. Camping can cause diarrhea. Sexual activity, patients who are immunocompromised. Sexual contact with immunocompromised patients can cause diarrhea. Seasonal, viral etiologies are the most common and seasonal. Clinical clues, bloody diarrhea, infective cause. Invasive diarrhea. This can happen in dysentery, in ulcerative colitis as well. This can present in patients with mesenteric ischemia. This can present with, in patients with hepatic encephalopathy or decompensated liver diseases. Dysentery, blood or pus, blood and pus in the stool. Fecal inflammation. Cachexia, weight loss, anorexia. Clues, clinical clues, signs of in elderly with cachexia, anorexia, and weight loss. Think of any tumor underlying. Collect stool sample for analysis if severe, bloody, persistent diarrhea or if there is an outbreak suspected. So what does a stool RE can show? Leukocytes, primarily in infective causes. So community-acquired or traveler's diarrhea, test for Salmonella, Shigella, and Campylobacter, E. coli, 0157H7 antigen, and Clostridium difficile. Nosocomial diarrhea, test for Clostridium difficile toxins A and B. Chronic diarrhea, consider Giardia, Cryptosporidium, Cyclospora, and Isospora belli can cause chronic diarrhea. Immunocompromise, test for Microsporidia, Mycobacterium avium complex, and cytomegalovirus. Again, patients who are immunocompromised or going through any chemotherapy or as are immunocompromised have post-transplant are prone to get infections from cytomegalovirus, Mycobacterium avium complex, and Microsporidia. These organisms produce diarrhea which are for longer period of time, and that needs adequate antibiotics, longer treatment, and adequate treatment. Consider antibiotic therapy and notify health department. It is very, very important to notify if there is an outbreak to your health department. This can help secure and treat many other patients who are not even aware of this outbreak. So continuing rehydration, electrolyte replacement is the mainstay of treatment. You need to rehydrate this patient adequately and promptly. How do you do that? You can give this patient oral rehydration or IV rehydration if the patient is in severe or moderate or severe, if the patient is severe or moderate dehydrated. As much as the frequency of loose stool increases, there is increased risk of dehydration and hypoperfusion of the organs. So what do you have to do? Replace IV fluids. Again, the mean arterial pressure should be around 75 to 90 in patients who are in hypovolemic shock. How do you treat? Large bore cannula, fluid rush, and empirical antibiotics. These are very, very important. Antimotility agents. This can help patients symptomatically. It's a supportive care. Decrease the frequency of diarrhea or loose stools. But the organisms which are producing toxins, antimotility agents are not recommended because it can accumulate. It can cause accumulation of toxins inside the GI system and hence can cause more problems in a patients who are going through diarrhea with toxins. Antibiotics, very, very important. If a patient is presenting with fever, bloody diarrhea, if you're suspecting any organism, any outbreak, empirical antibiotic is important. There are lists of them. Empirical antibiotic is very, very important in these patients. Probiotics is our supportive care and thought to be of high yield and important, especially children. So these probiotics help and support and decrease the frequency of loose stools and give a supportive care to the patients. Antiemetics. If the patient is going through vomiting, prescribe antiemetics. Symptomatic relief. Antiemetics before meal is highly recommended. Bismuth salicylate can be used. Dietary restrictions. Avoid things that cause diarrhea. Avoid taking food from a vendor. Avoid going out and drinking unpurified water. Hand washing is also very, very important, and one should encourage patient for hand washing. One should tell the patient to prevent from unnecessary exposure or contact with the people who are already going through such diseases. Dietary restrictions. Patients should avoid milk products for some times because it can cause intolerance, lactose intolerance. Avoid spicy food. It can exacerbate pain. So some special patients. There are few category of patients that can be affected with diarrhea. For example, immunocompromised. Small alteration in bowel habits or fluid loss can cause a huge amount of problems in a patient who are immunocompromised. Children specifically. So, in diarrhea in pediatric population, well, you need to realize children need hydration status. They must be having adequate hydration status for good growth, mental development, and for other specific things that they need to for what they need to have adequate hydration. If aside from sepsis, aside from septic shock, hydration status is very, very important in pediatric population, especially who are going through a diarrhea. How a patient can present, how pediatric population can present in dehydration: sunken fontanalis, increased skin turgor, dry mucus, tachycardia, decreased urine output, decreased oral feed, decreased oral intake. So what to do in these pediatric population? Needs aggressive treatment. If the child is not feeding, is not taking orally, this patient needs admission and should be given IV fluids. Pediatric population, rotavirus carries 50% of the weightage of diarrhea. But the good thing is self-limiting and can disappear within a few days' time. But again, with pediatric population and diarrhea, patient needs adequate hydration. Hydration is must. Elderly males. Likewise, in children, elderly males are also prone to get diarrhea. So change in bowel habits or dehydration can cause huge difference in patients, especially elderly patients. They cannot take orally. They're not taking adequate amount of fluids, or because of certain diseases or certain complications, or they're lethargic, or they're agitated, irritable. So these patients need extra attention and aggressive fluid therapy in hospital, and should be given adequate ample time and fluid resuscitation in emergency and inpatient services. Next, immunocompromised. Immunocompromised, especially in the patients who are post-renal transplant, who are going through chemotherapy because of any tumor progression or anything underlying diseases which warrants a chemotherapy, they are prone to get prolonged duration of diarrhea. For example, a virus that can cause diarrhea in immunocompromised, cytomegalovirus, Mycobacterium avium complex. These can cause diarrhea in these patients and prolonged duration. So HIV and AIDS, CD count of less than 400 can cause diarrhea. So what to do in this patient? These patient needs in-hospital treatment. These patient needs extra care. These patient needs a massive amount of or aggressive fluid resuscitation for the organs to be perfused adequately. Travelers, patients are susceptible for E. coli and other infections, especially travelers who are going to countries where medical facilities or medical problems are high. Medical facilities are not well developed. Poor sanitation system, poor water hygiene, poor hygiene. They are susceptible for infections. If there is any outbreak in that country, if the person is traveling to certain countries, especially with the developing world, where the patient can have can get the outbreak or epidemic viral or bacterial infection which are causing diarrhea. They can be getting those infections from those countries while coming back to their own home or homeland or country. So traveler's diarrhea, also the patients who have a history of traveler's diarrhea should be given adequate attention and treatment, should be investigated, and should be told to the national health authorities for any outbreak or anything that can help to other countries and to your country as well. Disposition. Disposition is a very, very important part of emergency department. You have to make sure why this patient is being discharged or sent home, and on what ground, on what reason this patient needs hospital care, and why this patient can be managed at home if not in hospital. So the patient should be given about guidance about symptomatic treatment. For example, if the patient is having a viral gastroenteritis or the diarrhea is due to any viral etiology, ask the patient to rehydrate if the patient can take orally. Rehydrate is the mainstay of treatment. Most of the time, viral etiologies are self-limiting. They resolve within a few days' time. But during that time, what to do? Rehydrate. Diet. Clear fluids. Encourage increased amount of fluids. If a patient is passing loose stools, encourage loose fluids after he or she passes loose stools. Encourage fluids after every episode of vomiting or diarrhea. Decrease sugar intake, because sugar can cause increased diarrhea. Few simple and solid foods. It is recommended to avoid coffee. It is recommended to avoid things that caused diarrhea. It is important to avoid food from outside, heavy fatty meal that can cause malabsorption syndromes. Take simple diet, simple soft diet is highly recommended in these patients. Strict hand washing. Hand washing is also a very, very important part in education and preventing organisms which can cause loose stools and vomiting. So hand washing, it is important part of one's hygiene. Patients should avoid contact with the patient who are already exposed and are already diagnosed or going through any diarrhea or viral gastroenteritis. Limit unnecessary contacts. Follow-up. The patient should be asked to and counseled about the follow-up in inpatient department after every certain amount of time to know if the patient is improving or if the symptoms are improved or not. So disposition is at times very, very risky. Disposition is also important and risky at times. You need to define why this patient can be sent home, and this diarrhea or loose stools is causing no more problems in this patient and can be sent home on oral fluids or on these guidance. But who needs admission? Who needs admission is also an important part of ED emergency department. What should be the outcome? Where should this patient be sent to for further management? For example, if the patient is immunocompromised, that patient needs admission. That patient needs aggressive IV fluids and fluid therapy. If the patient is hypotensive, despite fluid resuscitation, this patient needs admission. For more IV fluids via central lines, look for any various diseases that can cause severe dehydration, organisms that are causing this severe dehydration. So treat septic shock in this patient. Patients who cannot take orally, who cannot tolerate orally, despite fluid resuscitation, despite antiemetics, should be admitted and should be taken care in hospital department. Patients, pediatric population with severe hypertension or severe dehydration should be admitted, given IV fluids. Elderly patients should be taken care of in hospital. So, what are the recommendations for patients should be to be admitted? Look for vitals. If the patient is still hypertensive with adequate fluid resuscitation, this patient needs admission. This patient might go into septic shock if patient is not being treated adequately and with more fluids. So, in this lecture, I try to explain how to approach a patient with acute diarrhea. What sign? What are the vitals you should be considering in patient with acute diarrhea? How to check for fluid hydration status in these patients, and how to look for things or red flags or warning signs that can make a blink in the eye that this patient needs adequate treatment and should be given ample amount of time and treatment in emergency department. Next was, what are the organisms that can cause diarrhea? What are the things that need to be looked into in a patient with acute diarrhea with lab investigations, for example, stool RE, complete blood pictures, electrolyte imbalance? How to manage a patient with acute diarrhea? How to resuscitate this patient with acute diarrhea? Whom should be given oral hydration? Whom should be sent home with oral hydration? And whom should be given IV fluids and IV hydration? Next, what would be the outcome, or what are the differences in special population, for example, immunocompromised pediatric population and elderly males or females? What should be the disposition of patients who are coming with acute diarrhea? What sign or what symptoms warrants extra more lab investigations and inpatient care? And what are the signs and symptoms when achieved can be beneficial for patient and can be sent home on medical therapy? Thank you for watching.